Hello everyone and welcome along to this ESC webinar to coincide with World Contraception Day 2023. My name's Michelle Cooper, consultant gynaecologist from Edinburgh in the UK and one of the co-chairs for this session. The theme for this year's World Contraception Day centres around choice and options, hence our title, Your Life, Your Choices, which we can all agree is integral to sexual and reproductive healthcare. If you're posting on social media about this event, please do use the hashtags WCD2023 and hashtag Power of Options to help increase awareness of this important message on this special day. We are delighted to be joined by two fantastic speakers, Professor Richard Anderson and Professor Kristina Gemzell-Danielsson, whose work has significantly impacted reproductive options as we know them. So it's very fitting that they're with us today and we will hear more about them shortly. I also want to say a thank you to our sponsor for this event, Gideon Richter, whose generous support has made this webinar both possible and freely available. So we're hugely appreciative to them. I want to take this opportunity to draw your attention to the next ESC World Congress, which will be held in May next year in beautiful Bilbao in Spain. So do keep an eye on the website for further information about how and when you can register. And lastly, if you're not already an ESC member, do really think about joining us. It's a fantastic community to be part of, and you will have access to some great resources to support your clinical practice and education, as well as reduced conference fees and several other member benefits. You can follow the link on the website for more information about how you can become a member. And I'm now going to pass you over to my co-chair for this session, Karen, who will introduce herself and tell you more about the rest of the session.
Thank you, Michelle. So my name is Karin Emtel-Ivarsson. I'm a registered nurse midwife, having a postdoc position here in Sweden, at Stockholm, at the Karolinska Institutet. I'm also working at a youth clinic here in Stockholm, and I'm also a member of the Science and Education Committee within the ESC. So the ESC aims are to be a leading professional society working collaboratively in Europe and beyond to champion evidence-based education and research in sexual and reproductive health and rights, including facilitating people's informed decisions in choosing and using contraception. And benefit of being an ESC member is that you can connect to ask questions and submit comments about this webinar on the docmatter.com. And you are very welcome to this webinar and some practicalities. We have the Q&A button, so please click on that to ask your questions. And you can also upvote each other's questions. So just click on thumbs up, the sign on that. A selection of questions will be addressed after the presentations. However, unanswered questions will be addressed and added to the ESC website.
So it gives me great pleasure to introduce our first speaker for the session, Professor Richard Anderson. Richard trained in obstetrics and gynecology in Edinburgh, which included a WHO research fellow post in hormonal male contraception and then subspecialty training in reproductive medicine. He was appointed to the MRC Human Reproductive Sciences Unit in 1998 with a consultant post in reproductive endocrinology and infertility at the Royal Infirmary of Edinburgh. He was appointed Chair of Clinical Reproductive Sciences at the University of Edinburgh in 2005, and over subsequent years established a research group investigating the female reproductive lifespan, as well as several clinical studies developing our understanding of novel neuropeptides and human reproductive function in men and women. He is a past coordinator of the ESRI Special Interest Group in Fertility Preservation, a member of the HFEA Scientific and Clinical Advances Advisory Committee and the ESRI Executive Committee. And we are delighted that he's able to join us this afternoon to talk about where we are at with contraceptive options for men, something that I'm sure many of us will be eager to find out more about. Over to you, Richard.
Michelle, thank you very much indeed for that introduction. I hope you can see my slides okay. And also many thanks to the ESC for the invitation to join in celebrating World Contraception Day, which is fantastic. So yeah, I hope to give you a bit of an update about where we are in development of new methods for men. I don't have any particular relevant disclosures other than I have been and continue to be an investigator in this field. So you'll all be painfully aware of how limited the choices are for male contraception at the moment. But what's striking is that actually at some point in their sexual lives, pretty well everyone has experiences of male contraception. So it's not a rare or esoteric thing. It is something that everyone knows and uses about, and yet the choices are extremely limited and really haven't seen any significant developments for many, many years. But the male reproductive tract is actually full of potential targets that we could approach for male contraception. There's the endocrine control, essentially the same system as in the female, with the gonadotrophins driving hormone production and gametogenesis. There are lots of targets within the testis reflecting processes specific to spermatogenesis and meiosis that go on in terms of producing all the millions of sperm that are produced every day. And there are potentially post-testicular targets. And of course, that's our old friend and favorite, the vasectomy. But there are also lots of biochemical processes that go on in the epididymis that are related to sperm maturation that are actually very specific to the testis and don't occur anywhere else in the body. So despite these lots of opportunities, we still haven't had huge progress. All the progress in clinical trials is really in the field of the hormonal approach, and this goes back a long, long way. And essentially the same principle applies as for hormonal female contraception, whereby you give a sex steroid essentially in larger than physiological dose. And that could be testosterone itself or another androgen. It could be a progestogen. Men are very sensitive to progestogens, despite progesterone having no known physiological function, or a GnRH analog, and you switch off gonadotrophin drive to the testis. So the lack of LH stops testosterone production, and in combination with the lack of FSH stops spermatogenesis. And of course, if you stop Leydig cell function and testosterone, you need to give back an androgen as well. So essentially, as you well know, very comparable to the female situation. And the concept for giving steroids or testosterone specifically to suppress spermatogenesis has been around for many, many years. This is a slide from 50 years ago, essentially, showing that actually at that time, daily injection of testosterone propionate, a very short-acting testosterone ester, results in rapid sperm suppression. All of 7 men included in this, but they all became azoospermic. And then equally importantly, they all went back to normal afterwards. And you'll notice, of course, these are the old days when men had sperm counts of about 125 million per mil, which you'll be pushed to get these days. And essentially, we've been refining and replicating this type of study for many years since. And there were a whole bunch of studies undertaken through the 70s and 80s to look at different mechanisms and different approaches, and including testosterone with progestogens. But it was really a couple of WHO studies in the late 80s, early 90s that really moved the goalposts to really showing that this could work as a contraceptive. So they didn't have a product. They were using weekly injections of testosterone and ananthates. But what they wanted to know was, could hormonal suppression of spermatogenesis be a contraceptive? So they did 2 studies, one where men's sperm counts were followed until they went down to azoospermia. And actually, that's 70% of the guys, 30% don't suppress down to 0. And they then used that as an only contraceptive for a year in stable relationships, and there was 1 pregnancy, the paternity of which has been subject to some discussion, perhaps. And so that demonstrated that azoospermia was good, but how low did you need to go? Was 3 million low enough? And that was the next study. And you'd certainly know if you saw a guy in an infertility clinic who had a sperm count below 3, that was a pretty good cause of his infertility. But that's not the same as when it's someone with normal spermatogenesis and you're suppressing that down. So in this study, a rather bigger study, and of course, many more men entered the efficacy phase of 92%. of guys rather than 70%, and they went on to use that as for contraception for a year. And overall, in that study, the pregnancy rate was a very respectable 1.4 pregnancies per 100 woman years. So really not far off what you'd get with the use of the combined pill. And indeed, even when you looked at just those guys who had some sperm present but below the threshold, the pregnancy rate was about 8, which is at least as good as condoms. So, you know, overall, this was certainly as good or better than any currently available reversible male methods. And these studies gave us a wealth of other information as well, such as how low do you need to go to have a good cutoff for contraception? Of course, that's a slightly philosophical question as much as anything else. But currently, the established norm is that sperm counts below 1 million are the target for a hormonal male contraceptive, and that will give a very low pregnancy rate. Quite why every man taking this type of preparation doesn't become azoospermic remains unknown. There's discussion about whether it's ethnicity. Men of Asian origin seem to suppress rather more reliably. Could it be diet? And various testosterone-related metabolism, things like androgen receptor structure, or perhaps just continuing very low amounts of testosterone still produced by the Leydig cells in the absence of detectable LH, perhaps enough to just keep a little bit of spermatogenesis going in some men. As you see here in this tubule, on this sperm here, you see normal spermatogenesis, whereas this tubule adjacent from the same testicular biopsy, actually Sertoli cells only and no mature beyond spermatogonia. So one of the problems in the field at that time was there was really very little interest pharmaceutical industry of testosterone preparations. We had Sustanon around for many years. Pediatricians used oral testosterone undecanoate, and there were testosterone pellets available in some countries in the UK, but not more widely. And we used them quite a lot in our clinical practice at the time for treating hypergonadal men, because you could put in 600 milligrams of testosterone pellets, and that would produce normal testosterone levels for about 6 months. And the pharmaceutical industry started becoming more involved. You remember this was the time when the male menopause was getting lots of publicity for good or bad, and companies developed gel was starting to become available, patches came and went, and even a little pellet you put on your gum also came and went. And we were using these testosterone pellets for our contraceptive trials because they had the best pharmacokinetics. They lasted many, many months rather than the Sustanon lasting just a couple of weeks. And actually, we did a series of studies combining these testosterone pellets with Implanon, which was again just coming onto the market actually in those days as a long-acting reversible contraceptive for men. And the concept here was the progestogen, the Implanon, did the suppressing, and we were giving physiological testosterone replacement to minimize the sort of high androgen side effects that we got in those WHO studies, which were using really quite large doses of testosterone on its own. And in these studies, we were able to demonstrate that it really is the progestogen that does the work here. So you can see men's sperm counts falling with 1, 2, or 3 Implanon, and you can see really men need 3 of these Implanon to really get a good dose of ketogestrel. And you combine that with physiological testosterone replacement. And you can see with this combination, you're really getting very good rates of spermatogenic suppression. So that was all looking very good. The pellets have their disadvantages. And actually what really was the next game changer was shearing producing libido, injectable testosterone undecanoate, which of course in normal clinical use in hypergonadal men will last for about 3 months. So a huge advantage over previous injections. And what that really led to actually was a remarkable shift with pharmaceutical industry involvement in designing and running male contraceptive trials, which was a real step forward in the field. And for this, actually, we saw a fantastic collaboration between shearing with their testosterone undecanoate, the libido, and Organon with their Implanon. Although actually, having seen our data that you needed 3 of them, they re-engineered a man-sized manplanon, with much higher release. And they actually designed 2 versions of this for this particular trial that they ran in collaboration with Schering. And there were very good rates of spermatogenic suppression and some other interesting things that were novel to the field, actually. So it was very stimulating having industry involvement, because they brought in placebos, and they also introduced a centralized semen analysis as part of this trial. But as you'll all be familiar, those companies changed direction quite big time, and actually they both withdrew from male contraception shortly after doing these interesting studies. So there was a peak of expectation and then a trough of despair thereafter, as is so often the case in drug development. Meanwhile, WHO was moving slowly forwards and was also keen to explore testosterone androstenedione, but their choice of progesterone was norethisterone. Been around a long time, huge experience with it. Slightly complicated drug endocrinologically, because actually it's converted into ethinyl estradiol as well. So you've got, perhaps a slightly more complicated metabolism. But this graph here shows data from colleagues in Italy, from Kristina Gemzell-Danielsson, who explored different regimens of these 2 compounds, different doses, different intervals, showing that actually, if you gave them both at 8 weeks, you got really nice consistent suppression here for up to 48 weeks. And that led to the design of the next big WHO trial, which was exactly that regimen that Kristina had demonstrated: norethisterone, testosterone androstenedione, 2 separate injections given at 8-week intervals, but with the idea that, in theory at least, they could be combined into a single injection at some point in the future as a potential contraceptive. And the aim was to recruit 400 couples, and again, 1 million per mil as the cutoff, and then 52 weeks for couples using that as their only contraceptive. So excellent suppression, very, very good suppression. Just about everybody, 96% of men entered the efficacy phase, and the great majority went on and completed the whole trial. There were a couple of conceptions, 4 pregnancies overall, all within the relatively first few months of the study. 2 actually had a sperm count of less than 1, and 2 in guys where there was the thought that they had shown a little bit of rebound above the threshold, despite ongoing injections on time. But overall, as you can see, an excellent contraceptive regimen here, a Pearl index of 1.59, just really as good as the combined female pill. Now, this study has had an awful lot. It's had more newspaper articles written about it than most of us have had hot dinners. I've lost count of the number of times journalists have rung me up and said, "Oh, wasn't that study a disaster?" Well, no, it wasn't. It was an absolute success. But the reason it's got the controversy is because it was discontinued slightly early because of concerns at WHO over some of the side effects. And they were mood related. But actually, if you look at the number of men who discontinued the study due to side effects, it was remarkably small. There were a few, but overall, actually, only 6% of men withdrew because of side effects. And I think for a novel contraceptive study, that's actually incredibly low, when it was a pretty arduous study, lots of visits, lots of injections, and really quite a complicated study to take part in. So overall, it was a significant success. But it hasn't really got further than that. And what has really taken over as the leader in the field has been work by the NIH, CHD in the US, in combination with the Population Council, who have really taken a different approach, actually. They've taken forward the idea of men doing their own self-administration of contraception. And so for this, they've been exploring testosterone gel, which is much more widely used in the US as a HRT for men than injections are, and with the novel progesterone nesterone, or segestrol as it's also known. And this is a Population Council progestogen. And it's extremely potent. It's very, very selective progesterone. It's actually already available in contraceptive rings, such like that, because the problem with it is it can't be absorbed orally. It has to be taken parenterally, but it's well absorbed across the skin, so it can be mixed with a gel to give you a good dose of steroid administration. And in preliminary studies, what the NIH and the Pop Council demonstrated, and this is work led by colleagues in Los Angeles and Seattle, Christina Wang, Stephanie Page, and colleagues, they showed that at different doses, you could get great sperm suppression with men rubbing this gel on every day. So this here in the white, this is the testosterone only, having not much effect, but when you combine it with either 8 or 12 milligrams a day of nesterone, you get fantastic sperm suppression. And so these were sort of early preliminary studies to show that it could work. And they were wanting to check the dose. You can see here that 8 milligrams was as good as the 12. And so that really led to the easy plan to go on and develop that as an 8 milligram of nesterone for a bigger trial and really, again, look at contraceptive efficacy. And so that's what's going on at the moment. And we're taking part in that in Edinburgh. And so, in fact, so the next speaker, Kristina, is also running a group of stud patients using this in Stockholm as well. So, yes, this was the key finding, that nesterone with testosterone gave you great suppression in a high proportion of men. They could be combined in a single gel, and there was some testing out to make sure that it gave the same absorption as if they're applied separately. And so that's what we're testing out, this dose. Men put it on every day. When their sperm count gets down to less than 1 million, then they go on to a year of efficacy, no other contraception, count the babies, recovering. And it's going extremely well. Preliminary data have not yet been released, but I can certainly tell you there have been remarkably few pregnancies. It's really been extremely effective, much more so, I think, than many of us were thinking. And this is going on in a whole bunch of places around the world, across the US, as I say, in Sweden, as well as in the UK, in Italy, Kenya, and actually in other places in Africa have been joining us as well. And there's now heading on for 470 couples in the study, and we're looking forward to a formal interim analysis very soon. I think some data are going to be presented at FIGO in a couple of weeks' time. So what else is on the news? So that's where we stand in terms of big clinical trials, but there are lots of other things bubbling under. There are other synthetic potent androgens. There are some of these DMA, they combine, this is the one, the MNTDC is also a progestogen as well. So one drug can give you both the progestogen and the androgen and last for a long time. Other progestogens that could be used actually in male or female contraception. We've talked about nesterone, but also levonorgestrel butanoate, which has been a drug of investigation for many years, very long-acting injectable method, potentially like a sort of ultra-long-acting Depo-Provera, and novel antagonists as well might be of value. But there are also lots of targets and lots of interest in other non-hormonal approaches, and there's a list of them here. One that is, I think, particularly interesting is the retinoic acid receptor antagonists, which has been getting quite a lot of publicity recently. They are certainly very good. This is a retinoic acid inhibition. It inhibits the synthesis of retinoic acid, this particular drug. And you can see here in a study in rabbits, for some reason, gave very good sperm suppression and fully reversible. And there's a whole lot of synthetic versions of drugs that either prevent the production of retinoic acid or, as here, actually are receptor antagonists that are very good sperm suppressors. And there's a couple of groups in the US that are doing a lot of work in this, including one that was reported quite widely in the newspapers not long ago, oral, highly effective, fully reversible method in mice. We await trials in men with eager anticipation. So we could also try and develop a better vasectomy. You'll all be familiar with the limitations of vasectomy. It's quite a palaver, doesn't have a zero failure rate, very poor to reversible. Could we have a better approach? And there's been a lot of interest in injecting other substances into the vas as a sort of a blocker, or even a sort of a chemical treatment that damages the sperm as they go past. So it doesn't cause a physical obstruction, but it basically chews the sperm up as they go past. And one such is this vasal gel compound. You can see here it's been injected into the vas. doesn't completely block it, and this was in a rhesus monkey, but there is the opportunity for it to either leak from the vas, or the injection doesn't quite, hit the vas, and there's obviously not going to be a great result from that. But that is actually also starting to go into clinical trials, I think. The Male Contraceptive Initiative has invested in this, and we hope to see results from clinical trials underway quite shortly. But of course, the reality is that if you go down to your local pharmacist, it's still condoms, or go to the family planning clinic as a vasectomy. We still don't have big industry involvement or being perhaps convinced that this really is a winning proposition. So that remains to be changed. Regulatory wise, it's a novelty. The FDA have never had the need to work out how to approve a male contraceptive that wasn't a barrier method, essentially. It does have the slightly strange situation as one person is taking the drug to prevent someone else getting a condition. And there are obviously issues with it takes a little bit of time to work, but of course, so does a vasectomy. And not all men are responders. So these are all issues that we need to try and improve, but they are in large clinical trials. The hormonal methods are very exciting, but not yet in clinical trials. But I think there are now sufficient breadth of activity there, is that, this will come to fruition. These non-hormonal methods, I think, are also extremely interesting and will happen one day. But I think what really is driving this is, of course, is that what's so striking about talking to couples who are taking part in the studies is the enthusiasm of the female partner that they want this to happen. They want to share the burden as well as the responsibility for contraception. And so, we see fantastic enthusiasm in our trial participants who want to do this. So, which is great to see, even in really very young couples. There's couples in their early to mid-20s who have to use this as a contraceptive for a year, and they are just loving it. So thank you for the opportunity, and I hope it won't be too long before this domestic scene is changed to one of reality. Thank you.
Thank you, Richard, for that fantastic talk. Now, we do have a few questions in the chat box, but while people are starting to put those through, I wonder if I might ask a question first. I'm just interested, how does the side effect profile compare with the testosterone combination compared to earlier male contraceptive trials? And what, if any, long-term consequences or complications would you anticipate?
Yeah, so side effects and long-term consequences are clearly for later sort of bigger studies than we're doing at the moment, Michelle. But it's absolutely a fair comment. With the WHO's trials, I think it's important to recognise that they did have side effects from high doses of testosterone, like acne, for example. But these are not issues that we're really seeing with the normal physiological doses of testosterone. Those industry-sponsored studies that I mentioned were quite interesting because they did have a placebo, so you could see what was perhaps more common in the Verum group rather than the placebo group, and there were some minor mood changes. People do feel a bit different. Women are going to be rolling their eyes at that, of course, and saying, for goodness sake, we've known about that for 40 years. Catch up, boys. But it is interesting. People often do say, I feel just slightly different, but rarely, and none of the guys we've had, it's enough for them to think, actually, I just don't want to take this anymore. It's been really quite minor. But because actually there are often quite a lot of positives, their female partners are loving not being on the pill or not having to use any contraception, and they're feeling great, and and the men are enjoying this is a novelty, and quite a few were saying that it's improved our sex lives. This has really been quite a positive part of our relationship doing this, which is very good. I think what we're going to have to be thinking about for the long term is any more metabolic changes. But I think, again, what we're seeing in the current trials are an awful lot smaller than when we were using the bigger doses of testosterone. So that has become much less of a concern over the years, but it'll be something for the long-term studies for the future.
Thank you. So we do have a few questions in the chat box. There's one here. Can you speak to at all why the work on manplanon was discontinued? Comment here that actually it could have been a potential opportunity, and I suppose broadening that out, you mentioned about the reduction in interest from industry towards male contraception around that time. What do you think some of the drivers might be for that?
So it was a very exciting time because when we started doing our own studies, as I mentioned, with the testosterone pellets, there was no industry involvement. When libido started to become available and Implanon was on the horizon, both Shearing and Organon started to be more seriously involved. And we and others did surveys of men and women, showing that men and women wanted novel male methods. And interestingly, the power brokers in both companies started really getting on board that this was something to do, which is quite remarkable because, as one of the questioners says, these are companies run by middle-aged white men who are not interested really, but they were Europe's big contraceptive companies, so they were interested in the field. So it was remarkable that the field as a whole started to get them on board. And they invested really quite a lot of money. They had to re-engineer the Implanon to do this specifically for this trial. This was a big new game that they were actually committed to. And sadly, it wasn't because the trial didn't work that they discontinued it. It's because both companies essentially got taken over and their commercial priorities were elsewhere in contraception. And we've seen the impact of that in female contraception as well as in the male in the subsequent years. And sadly, we haven't got any other big players in the field who've stepped into the breach since then. But you'll be familiar with the fact that the Population Council have taken products to the market before. The original implants were a Population Council preparation, and now we all think of it as being Nexplanon. It's as common as anything, but that was originally the Pop Council who got that prototype on the market. So we hope that with the big trials that are going on at the moment, sufficient evidence will be presented that this really works and enough people want to use it.
Yeah, thank you. Another question here. In Switzerland, there's a trial at the University of Geneva on thermal male contraception, and that many family planning centres are offering this as a non-hormonal option. Do you have any thoughts or comments on that?
Yeah, gosh. So actually, this is something that's been around since about the 60s, actually. And the French have also been very keen on it. It seems a particularly central Gallic methods that you wear these special underpants that heat up the testes, and they do actually very reliably suppress your sperm count. But they haven't really got caught on elsewhere. You have to wear them actually for I'm not sure exactly, but something like 18 hours a day or 20 hours a day. So they're not quite so user friendly as you might think. But certainly, they don't have any other side effects. They don't affect hormone production. So for some men, they certainly seem to work and fantastic, because we're all about opportunities and choices here. We don't want to say that one is the right answer. It's about lots of options, then people find the right one for themselves.
Yeah. And I suppose then one final question, and this is a bit of a tricky one, and you've spoken to it a little bit already, but the question is, someone has asked that they would like to hear more on why you think there are so fewer options available for male contraception. There's a comment that decision makers are overwhelmingly male, and a feeling that may be one of the primary reasons, as you mentioned earlier, for the limited advancement of male contraceptive options, but also this idea that contraception is a female responsibility. Do you have any comments, Richard, you want to make on that?
Yeah,
so it's wider barriers.
Yeah, I think these are very significant concerns. And I think if you go back to when we were just started those WHO studies and thereafter, so in the 1980s, that is actually, a time when, things have changed a lot since then, but it was absolutely the case that the contraception was a female business. And, And also from women. You know, when I remember doing dozens of radio interviews where the guy would say, well, I'm going to walk down the street and I'm going to ask 10 women if they trust a man to take the pill, and they're all going to say no. And he did, and they did say no. But when he asked them, would you trust your partner to take the pill, then you sometimes get a different question. But yeah, so there has been a perception that actually women want to retain control because they don't want to be relying on someone else, and then they're the ones that are left, you know, carrying the pregnancy. But I think that has changed. And as I said, in the couples who are taking part in the studies that we've got these days, the women are fantastically positive about it. And, you know, this is changing. We have seen many different attitudes in society, with people recognizing that contraception is a burden, as well as actually a wonderful thing to be able to have available, and that sharing that is part of a mature relationship, effectively. So I think we still have a bit too much of the you know, men running the show and being reticent about this, but you know, things are changing.
Yeah, for sure. Thank you so much, Richard, for, I'm sure everyone will agree, a fantastic talk, a great overview, and I think we can all watch this space to see what happens over the coming years. So thank you again for joining us this afternoon and for answering all the questions. I know that, Richard, you do need to nip away, so will not be here for the rest of the talk, but thank you again for being with us.
Been a pleasure. Thank you very much. Thanks to the ESC for organising this.
So our next speaker, I'm so happy to introduce her, and also my professor, Professor Kristina Gemzell-Danielsson, who will present fertility choices for women. And now I will introduce you and read here. So Kristina Gemzell-Danielsson is professor and chair of obstetrics and gynecology at the Department of Women's and Children's Health at Karolinska Institutet and senior consultant at the Karolinska University Hospital. She is head of the research group at the WHO Collaborating Center for Research and Research Training in Human Reproduction at KI. She is an honorary clinical professor at Hong Kong University, Riga Stradins University, and an honorary fellow at Faculty of Sexual and Reproductive Healthcare, Royal College of Obstetricians and Gynecologists in the UK. She is a member of the International Committee for Contraceptive Research and Population Council, past president of the ESC and FIAPAC, and a current member of the FIGO Council. Her research is translational, with a focus on reproductive medicine, endometrial function, embryo implantation, comprehensive abortion care, emergency contraception, development of new contraceptive technology, and new methods for assisted reproduction, as well as her research has a focus on global health. So, very welcome, Kristina Gemzell-Danielsson. Over to you.
Thank you so much, Karin, and thanks to ESC for inviting me to give this presentation. Well, happy World Contraception Day. So I will address fertility choices for women. I use women inclusive, and well, in the current world of 8 billion. These are my disclosures. And this is an overview of the presentation. So I'll start with current trends in the global population, reproductive autonomy, opportunities and challenges. We have a lot of those. And then I will talk about recent or ongoing development, mainly in contraception. So the key trends related to global population that we see today, it's that the world's population is steadily increasing for centuries now, but slowing down in recent years. It is expected to continue increase until 2100. What has just happened is that India now has overtaken China with approximately 1.5 billion, and the largest growth is seen in Africa. We have an aging population, life expectancy is increasing, fertility rates decreasing, we have more older adults than ever before, and fewer young people to support us. Urbanization, so more people are moving to cities, and this is also expected to continue as people seek better job opportunities and higher standard of living. Then we have gender imbalance, for example, in China and India, where in some regions where more men than women live due to the cultural preference for male children. And we have migration. People are moving between countries or regions because of political instability, climate instability, to seek opportunities and safety. So fertility rates, that's defined as the number of children born per woman in a population. And as I said, over the past few decades, global fertility rates have been declining. In the 1960s, it was around 5 children per woman, and today it's around 2.4 children per woman. But obviously we have a huge regional and national variation. So some countries in sub-Saharan Africa, we still see fertility rates above. And in Europe, many countries, and Asia, below the global average. So there are several factors that have contributed to this decline. Improved access to education, particularly for women, with increased opportunities. And it's been stated that development is the best contraceptive. Social norms are changing. And then we have what was recently named as the main factor in the article that I reference here. That's access to contraception that has allowed women to have greater control over their reproductive choices. Now, when we talk about choices, we obviously have huge problems, and some of them goes back to this person. So it's clear that it's not people themselves who decides over their own fertility. If we look back briefly to the International Conference on Population and Development in 1994, very important achievements were made, and it was agreed that all individuals have the right to make informed decisions regarding their sexual and reproductive health, free of coercion, discrimination, and violence. And today we actually have this incorporated in the SDGs. So number 3 is good health and well-being. And then number 5, which is gender equality, also has a sub-goal that by 2030 ensure universal access to sexual and reproductive rights as agreed in accordance with the program of action of the ICPD. So this is extremely important. Effective contraceptive methods, safe abortion, and freedom from infertility are prerequisites for reproductive health. And sexual and reproductive health and rights constitute fundamental human rights, form a vital aspect of women's empowerment, and are key to the achievement of gender equality. So this is based on the ICPD 1994, and it's actually the basis for the whole development of society. Now, this is a reply to the previous picture we saw with Trump. And I think I love this. It's the former Swedish Deputy Minister. I think this is really a statement that women can make decisions, even pregnant women. And as Kofi Annan said, that there is no tool. No, unfortunately, I can't see it myself, but there is no tool stronger for development and empowerment of women or something like that. Now, so talking about choices, I think there is also frequent misunderstanding among policymakers that reducing access to contraception, and especially abortion, would increase birth rates. But I think if we look at Europe, it's really clear and demonstrated, if we look at our statistics, that high birth rates goes together with or is associated with choice and easy access to contraception and abortion. So you can see here, top fertility rates in Europe is actually Denmark, Sweden, Iceland, and France, while Spain and Italy are really at the bottom. Something I find really important, and in 2 days we have the Global Safe Abortion Day. That is the updated WHO abortion guidelines from 2022. So in these guidelines, there is a shift from looking more at the technical aspects, but to also include quality. And rights is incorporated throughout. It's also clearly stated that abortion is a human right. And then there is a focus on self-management and reproductive autonomy. It's very clear if we look globally, and this should be clear also to our politicians, that restrictions in access to family planning, safe abortion services, and post-abortion care is one of the main, results in unsafe abortion, which is one of the main cause of maternal mortality and morbidity. And the clear link between contraceptive prevalence and unwanted pregnancy should also be clear to all. And of course, contraception is important beyond the benefits for the individual user. It encourages productivity and participation. It addresses period poverty. It helps elevate women's position in society, and not only, as we said, for women themselves, but also for their children, families. And it's cost-effective, especially green contraception with minimal impact on the environment. So, is there a need for new contraceptive methods? Well, if we look around, we can see that there is still more than 200 million women, and if we add men and single women and men, this figure will increase, but who lack access to effective and acceptable contraception. And we know that more than 40% of all pregnancies are unplanned, and 56% at least results in an induced abortion, and unfortunately, many times an unsafe abortion. So if we look briefly at a short list of unmet needs in contraception, I think this could be longer, but I think we need improved, safe and green methods with added health benefits, on-demand methods as well as LARC methods, methods for dual protection, and as we just heard, reversible methods for men, long-acting, also non-hormonal methods, contragestion, and we also, of course, need improved access and use of existing methods, and that includes post-abortion and postpartum. So we need to remove barriers. Now, talking about LARC methods, they not only requires counseling and compliance, but also competence. So we need to ensure training of healthcare providers. We know how important it is with correct placement to ensure performance and also to facilitate removals. And this goes especially for the implants. These photos are from Uganda, and it's a study that Karin was involved with. So here we looked at a standardized way of removing implants. So implant is now the most popular method, and our mobile teams inserting implants, but the problem arises when women want to remove an implant. So we are looking at this new device, but also possibility to task share implant removal to primary care level. Also, the combined hormonal methods are also efforts to make them long-lasting, maybe not long-acting, but long-lasting. And this is an example with the contraceptive ring developed by Pop Council. Aloe vera, unfortunately, not available in Europe so far, but this is one ring that contains enough ethinyl estradiol and estrone to be used for 13 cycles, so that's 1 year. The ring technology and ongoing studies also allows dual protection. And that is a ring that is not only used for contraception, but also loaded with antiretroviral agents to protect against HIV, or it could also be other sexually transmitted infections. We also need to improve safety of the combined hormonal methods. So focus during later years have been to include natural estrogens. And the latest one is estetrol E4 that is now available in a combined or a contraceptive pill. Estetrol is not new. It was discovered by Professor Egon Disfalusi at Karolinska Institutet in the 1960s. And but he didn't really know, and we still don't know, the function of this fourth estrogen. It's intriguing. It's produced only during pregnancy. It's an enzyme in the fetal liver that is necessary to convert E2 to E4. And after birth, these enzymes disappear. During pregnancy, the levels and concentrations in the pregnant woman's blood corresponds to 55 milligrams estetrol per day. Now in the new pill, it's 50 milligrams per day. So I think this is a sign of safety. What's also interesting with E4 is that it has completely different mode of action compared to other estrogens, that it's an antagonist on the membrane ER alpha in the liver and the breast, which means that it blocks estrogen action in these organs. But it's an agonist on the nuclear ER alpha. So it has the estrogenic activity that we're used to from EE or E2 in vagina, endometrium, bone, and cardiovascular. So when it comes to safety and venous thromboembolism, it will take many years until we have the clinical data on VTE associated with the new pill. And I really wonder if we can afford to wait this long. And I think that we could look at the biological action and actually also to functional assays. And this is an ETP-based APC resistance assay. So it demonstrates induction of APC resistance by different combined pills and with known VTE relative risk. And then Drovelis, the new pill, is indicated here. So you can see far below the gold standard EE 30 microgram energy 150 pill, and closer to the relative risk for VTE in women using no combined oral contraceptive. So my opinion is that it's actually time that we look at our clinical guidelines and that we should not wait. Now, if we look briefly at new drug delivery in contraception, we have methods that will allow on-demand or LARC delivery. So the microneedle patch, it has these really tiny microneedles that when they get in contact with the skin, so it's like a patch put on the skin, and then these needles dissolve and release drug or vaccine encapsulated in them. Then we have the micro chip system. This chip is inserted under the skin. It can be on demand or it can be for longer time. So it could deliver 30 microgram LNG, levonorgestrel, per day for up to 16 years. And we have another possibility also for long time delivery, which is a vaginal ring. So both these alternatives could be controlled by the user themselves, using your smartphone to turn it on or off. It could also be controlled by a healthcare provider, or, this is a little bit scary, by someone else. You really have to keep track of your iPhone. Then we have the electrospun drug-eluting fabrics, and this is also really interesting. It can be done like a small, thin paper sheet and contain different drugs released at different pace. So promising technology for the future. Now I will look at one of my favorites, and that's contraception. And for this, I use mifepristone as a model. So as we know, mifepristone, depending on the dose and the time of the menstrual cycle or pregnancy, can result in different effects: inhibition of follicular development, inhibition of ovulation, inhibition of fertilization, implantation, abortion or labor induction. And we developed an in vivo model where we looked at the effect of 200 milligrams of mifepristone after ovulation. So it didn't affect ovulation, it didn't affect the menstrual cycle, so the next menses came at expected time, and no effect on plasma levels of estradiol or progesterone. But at the time for endometrial receptivity, or the implantation window, you know, there is only a short window during the menstrual cycle when the endometrium is receptive and can allow embryo to implant. So if we look at the endometrium at that time, it's completely changed. And we actually did a clinical trial where women could use 200 milligrams of mifepristone on LH+2 once a month for up to 1 year as the only contraceptive method. And we looked at cycles where they had intercourse during the peak fertility days. We also compared to women with no contraception with exposed cycles. So highly effective method, but with a logistic challenge that is demonstrated by this one pregnancy, that women had to determine their LH peak each cycle for correct timing of mifepristone. So that's why we also looked at other alternatives, and others like Sharon Cameron and the Edinburgh group have focused more on low doses that inhibits ovulation, while we have looked at a little bit higher doses that would also target the endometrium. And different progesterone receptor modulators have been used, and also different modes of delivery of drug, pills, IUDs, rings. Progesterone receptor modulators can also be used for emergency contraception, and you know there is a lot of discussion around the mechanism of action. So for this, we have used an in vitro model where we constructed a 3D endometrial that well really looks like normal endometrium biopsy with a luminal epithelium. The cells retain their polarity, and we can allow a human embryo even to implant into this endometrial construct. So now if we look at emergency contraception, so we were involved with the WHO trials looking at USP versus LNG emergency contraception, and as the next step, LNG emergency contraception compared to mifepristone low dose. Later on is of course another progesterone receptor modulator, ulipristal acetate, that has been more widely implemented. So these low-dose mifepristone pills, as well as LNG EC, prevents follicular development and ovulation, but has no effect on the endometrium, which makes the efficacy less than compared to, for example, the kappa IUD, which we know will also act post-ovulation to prevent fertilization. And here this is demonstrated by efficacy of EC methods as pregnancy's first month after the use of EC method among 1,000 users. So you can see LNG EC, a little bit less effective than ulipristal acetate, LA or LA1, and then the most effective is the kappa IUD, which is of course also frequently left in place. But if we look at a higher dose of mifepristone, not a 10 milligram dose that is that was studied by the WHO, but 50 milligrams, we can't really see a difference between kappa IUD and mifepristone. And we believe that this is because the higher dose also targets the endometrium. Further evidence for the importance of target the endometrium is a recent study that we done. So the background is that LNG and ulipristal acetate EC is effective only when given before, but not after ovulation. So we have the in vitro data, and we also have data from clinical trials. And they prevent pregnancy by blocking or postponing the LH surge and hence disrupt ovulatory process, but they have no effect on implantation. So therefore, our hypothesis was that if we could target also post-ovulatory action, we would increase efficacy. And prostaglandins are involved in reproductive processes, including ovulation, fertilization, tubal function, and embryo implantation. So, headed by PI Raymond Lee in Hong Kong, we did a clinical trial where women were randomized to receive LNG EC plus piroxicam, which is a prostaglandin synthesis inhibitor, COX-2 inhibitor, or LNG EC plus placebo. And the results confirmed our hypothesis. So with addition of piroxicam, almost 95% of pregnancies could be prevented compared to placebo, which was 63%. Sorry. Now, if we go back to mifepristone and the higher dose that we think will target both ovulation and endometrium, we have recently initiated a clinical trial. And in contrast to the once a month high dose, this is easier because women can take 1 tablet a week, so 50 milligram once a week as a regular contraceptive method. And this clinical multi-center trial is now ongoing in Moldova. Sorry. So talking just briefly on added health benefits, something which I find extremely intriguing is also the possibility to use mifepristone to prevent breast cancer. And this is based on data from animal studies and studies that we have done in human breast in women with BRCA mutation and wild type women. And we can see that the cells that give rise to mutations and the initiation of breast cancer development can actually be reduced by the use of mifepristone. So this is really promising for the future. Now, the next possibility with mifepristone is contraception, or what could also be called menstrual regulation. And this is treatment at or just before expected time of menstruation. So this could be just induction of menstruation. It could also, of course, be disruption of a very early pregnancy. And it could be used for regular contraception or for emergency contraception. And then we actually come to something that we call VMA, or very early medical abortion. So when it comes to VMA, the protocols looks very different, and there is no real consensus on how to treat these really early unwanted pregnancies. Nowadays, we have highly sensitive pregnancy tests. Pregnancies are detected earlier and earlier. So the question is this safe, or do we miss diagnosis of ectopic pregnancy? Is it effective? And I would say that this is a bit unclear. We actually don't have much data. So what we have done is a large multi-center, multinational trial, including 1,500 women with pregnancies of non-confirmed intrauterine pregnancy up to corresponding to 6 + 0 days of gestation, or weeks of gestation. And the trial has just been completed. The first report will be delivered at FIGO in Paris. So for those who are in Paris, please come and listen on Thursday afternoon. Another thing that has really changed, and as I said, is endorsed by the WHO guidelines, is self-management. And the need for this was further stressed during the pandemic. And as you know, I guess FIGO endorsed the permanent adoption of telemedicine abortion services. I think it is really encouraging and interesting to see what has happened over the years. When we published the first paper on telemedicine provision of abortion, the Telegraph in UK reported this as something bad, dangerous, that women risk health by using abortion websites. Today, this has changed, and it's published by the same journal under Lifestyle. Abortion pills, everything you need to know, where can you get the abortion pill? So attitudes have changed. It has taken some time. And in conclusion, we need to ensure sustainable population growth, but I think that it's important that we do this by maintaining choice and reproductive autonomy, and that policies should be based on evidence. We need to work on removing stigma, because that's so dangerous. We have to consider climate changes and its impact on fertility and sexual and reproductive health and rights. And we have to ensure access to contraception with improved education, autonomy, reduced poverty, from very early to much later, which I would call contragestion. So thank you, thanks to all collaborators, and happy World Contraception Day, and in 2 days, happy, safe Global Abortion Day. Thank you.
So thank you very much, Kristina, for this wonderful presentation. So we have some questions in the Q&A, and it's questions about fertility awareness methods. One comment is that the 2-day method is quite effective, and that the symptothermal method is also quite effective according to the WHO. And in my experience, the writer says, these natural effective options are rarely presented, and why is this? And also a question about the fertility awareness methods that the participant would love to hear your opinion, Kristina, on the future of using apps for pregnancy prevention, with challenges and potential risks, etc.
Yes, I'm sorry, I actually deleted the slide I had on these methods because I didn't have time. But I think there is some new development, and it's a balance how much input, because that will also increase complexity and maybe user friendliness. But I think the apps, and maybe combined with a device that can help to measure at least body temperature, maybe give some other inputs, is a future possibility. So I think with the future we will see increased efficacy also, or effectiveness also for these methods, and I absolutely think that they should be part of the contraceptive smorgasbord.
Yeah, so thank you. And also I had some questions about that you have presented new research on fertility choices. And for example, you presented the use of mifepristone as a potential regular contraceptive method, as an emergency contraception, but also as a contragestive method at or just before expected time of menstruation, and also as an abortion method. Is mifepristone the ultimate pill, the ultimate fertility choice? And are there any negative aspects of using mifepristone? Are there any, or which obstacles have you met related to research on mifepristone?
Well, some obstacles. Yes. Well, obviously it's politically sensitive since it's known as the abortion pill. And I think that has really slowed down the development. But I think, yes, I mean, as is demonstrated by this nice graph that I got from Regine Citroquet, I think it holds so much potential. And also with the added health benefit. Now I talked about breast cancer because it's new program that we have developed, and breast cancer is the most common cancer among women, but it may also actually prevent ovarian cancer, so other hormonal dependent cancer. And we know that it can reduce heavy menstrual bleeding, pain, uterine fiber. So I think it has added health benefits. It has potential to be used really flexible, especially maybe in the 50 milligram dose. That's what I think, for emergency contraception, for regular contraception, for contragestion. But of course we need more data. That's why we need to do studies, and it's been really difficult to get approvals to do studies on mifepristone because of the political sensitive issue around abortion. Yeah.
Thank you. And also another question here in the chat. Thank you for an excellent talk. And contragestion is an interesting area to explore. In your view, how does it compare to the regular pill in terms of effectiveness and women's acceptability?
So when it comes to effectiveness and acceptability, it's really what we need to find out now in the ongoing clinical trial. And as we talked about barriers and difficulties to get regulatory approvals and so on. So it has taken a long time to come this far. And I really want to acknowledge Rebecca Gompers and Women on Waves. I mean, we do this together. And if you want to do something difficult, do it together with Rebecca, because she never gives up. So that's great. And also with funding from SIF and others that we have come this far. So now we will see. But from preliminary data, it should be highly effective. Of course, you still need to remember to take the pill, but studies have also shown that many women and others would prefer not having to take a pill every day, but maybe to take it once a week or once a month. But now we try the once a week. And the next step would be to look more at on demand. So I think, again, this is the flexibility that I think we need, because the the need changes.
Thank you. And another question on mifepristone is that it is not legalized in many countries around the world, especially Asian countries. Are there any similar alternatives in development that doesn't carry similar connotations as an abortion pill?
Well, this is so interesting what we call it. So when I talk about contraception, if we call that contraception, it's accepted. If we call the same treatment at the same time, the same conditions, but we call it abortion, then it's suddenly not accepted. So yeah, it could be in that we need to call it something else. You know, how abortion, medical abortion and surgical abortion is called menstrual regulation, and sometimes now it's called post-abortion care. So it could be that we have to be a bit flexible also with what we call things. When it comes to access, it's actually better in Asia, I would say, because China, India have production of different doses of mifepristone that is distributed, but not. Yeah, I mean this is a whole new area with how to get approvals for drugs. Yeah, so that's also barriers to overcome.
Thank you. And also, could letrozole be an alternative to mifepristone in the latter? Is if the latter is unavailable?
Yeah, so I didn't have time to include that, so thanks for the question. So, you know, now in the updated WHO guideline, letrozole is mentioned as an alternative to mifepristone. For induced abortion, it doesn't seem to be as effective as combination with mifepristone and misoprostol, but I think that also depends on the gestational length, and it may be that very early it could be more effective. I mean, there are studies from Hong Kong indicating this, and we are also, I think it's also worth exploring letrozole more for treatment of ectopic pregnancy. So that's also interesting ongoing work.
Thank you. And another question on estetrol. Is estetrol the future form of estrogen in contraceptive pills?
I think so. At least I think it, I mean, because over the years there's been great efforts. I mean, it was early on, it was recognized that it was the dose of estrogen that was associated with VTE risk, and then efforts to gradually reduce the dose. Then it was recognized that the estrogenicity could be enhanced or balanced by the progestin, the type of progestin. And then the next step was sort of to move to natural estrogens to have an even weaker estrogen or allow less impact on the liver. So I think we have come a step further with E4. And it can also be combined with a progestin such as drospirenone that is anti-androgenic without increasing the risk for VTE, and then with the good properties that we know that drospirenone holds. So yes, and that's why I say I think it's time now when we have this possibility. I don't really think that we can afford to wait for another 10 years or more to get the phase 4 or real world data. I think we have enough evidence to now make this the sort of first choice, and maybe we move down to EE pills to third choice. So that would be, I know I'm speaking a little bit out of, but I mean, this is my opinion. And then we need to see if others agree, and if we could update clinical guidance.
Yeah. So thank you very, very much. And now let's see. Yeah. So a big, big thank you, Kristina, for excellent talk.
Thank you.
And I would like to announce also or address that this webinar is recorded and will be available on the ESC website, which means that you can look at this or watch this webinar as many times as you wish during some weeks through the ESC website. Yeah, because we had some questions about slides and so on, but please go to the ESC website and watch the webinar many times. And lastly, we would like to thank all of you who have joined us here today, and also a big, big thank you to our excellent speakers, Professor Richard Andersson and Professor Kristina Gemzell-Danielsson, and also to our sponsor, Gideon Richter. Michelle, do you want to add something before we end this webinar?
No, I think you've said it all, Karen. I think just to echo a thank you to our great speakers, and it's so nice to have them speaking on that topic on World Contraception Day, which is a great opportunity for us all to celebrate the great work that we do, but also to recognise that there's still so much more to be done.
Yeah. So once again, thank you all for joining us here today, and have a really happy World Contraception Day. And we say bye-bye.
Thanks, everyone.
Thanks.